So what I did was a virtual live analysis. And so this, so that, and this is actually pretty easy to do on this population because we don't have a lot. But when you have a lot of cells, they sort of spill out a little bit. So you want to get rid of your doublets. And then I look at my 38 versus 138, and you know, my 38 versus 45, adjusting back and forth, and you know, so I've shown you this multiple times. So here's a 59-year-old female with a history of myeloma post-therapy. And so I look at time, and you can see it. I've got a significant fluidic disturbance here. I think it's running, the tube is running dry. So I want to gate that out. And then I want to have a singlet gate based on forward scatter area versus height. And I don't have a lot of doublets here. It's a pretty good singlet. But I make my gate. So I come through this gate and then this gate. And now I look at these two plots. And I'm looking at CD38 versus CD45, and this is what I see. And this is my pink gate. And I'm looking over here at I looked at CD138 versus CD38. And this is my green gate. So what I go back and I have these gates, I go and I color the cells from this gate, which are green. I activate that color in this plot. And over here, I show which cells are in the gate over here. So I'm able to look at them and adjust them. I can see how they fall. And I like to do an extra, just, you know, pull these cells through this gate to see if they're lying outside the gate. And then, so I have a combination of this gate, these two gates, and then you can see I have this big population, and over here I have my debris. So these are my sequential gating. I do time, singlets, PC, and I start with PC45, 38 separate, and PC38, 138 separate. But I then choose to put one under the other because I've validated between the two gates and decided that I've got everything included. And then I do my forward versus side scatter. And I also determine viability. I have a lot of debris here. And I have fewer events shown here because it's easier to see my major populations. But basically, I have some debris here. So now I'm ready to actually look for plasma cells. So this is my plasma cell gate with all those gates strung together, but not the viable cell gate. And I'm looking at CD138 versus 38. You can see my plasma cells. Looking at CD19 versus CD45. And you can see that I have some that are 19 negative, but they're all 45 good and bright. And I look at CD19 versus CD56, and here's some of the ones that are 19 negative. Most of them are positive, and I have some that are CD56 positive, but they're really spread out. They're not clustering nicely. They're spreading out over here. And I look at CD81 and CD27, and they've got really good expression. And I look at CD20 negative. So I look at CD19 versus kappa and CD19 versus lambda. I don't see a 19 negative population that's really monoclonal. You know, there's more kappa than lambda, but that's what we expect. So then I look at CD56 versus kappa and CD56 versus lambda. And you can see that I don't have a monoclonal population that's CD56 positive. And so this is no myeloma MRD, and the limit of detection, 20 myeloma cells over the number of viable cells, 0.0006%. So this is normal. And this shows you the types of 56 positivity and 19 Negativity, we have very few dim CD45 ones, but we do have some. And this is the type of thing you see when it's normal plasma cells, but they don't cluster in a very homogeneous manner. So, case 2, 45-year-old female with a history of myeloma post-therapy. So what are my initial gates? I look at time, and everything looks good. My fluidics look good. I don't even collapse down my time gate. And I must have a lot of cells because it's a pretty quick acquisition. And then I do my singlet gating. I have some doublets, but not a lot. And here I have my viability for determining the number of cells. I think I see my myeloma maybe. But anyway, this is low, small debris. And also this is debris. So then I start looking at my panels and my plots. So I look at 45 and 38. You see what I have here. And then I look at CD138 and CD38. This is what I have here. This is what my forward scatter would look like through here. But I want to check it out. So if I look at the cells in this gate, and I look at my CD38 versus CD138, you can see I got this dim. I'm losing part of my CD38 dim myeloma, most likely cells there. So I adjust the gate, so I get those dim myeloma cells. And so now I'm ready to look. And so my final gating strategy is time. It shouldn't be viability. It's singlets, and then plasma cells 45 versus 38, 38 versus 138, and forward versus side scatter. And then when I look, I can see I have this dim CD81 with dim to negative CD45. There's my CD38 and 138. And here's my 19 negative. They're all 19 negative, basically. And actually, it's very homogeneous compared to what you see with the normal plasma cells. They're 20 negative, 56 bright, and again, 81 dim. 27 is basically negative. And with my kappa and lambda intracellular, you see that they're all kappa positive and lambda negative. Now, kappa and lambda intracellular is a fairly easy assay to perform. There's just a few technical things you have to remember. We pre-lyse and wash, and we wash extensively so that we get rid of the cytophilic antibody that's sticking to the cell surface. We stain with our surface markers like CD19, CD56, CD45, etc. And then we use actually a proprietary agent. We use Fix and Perm. Is it Fix and Perm or Perm and Fix? And we get a really nice result. We've used it with kappa and lambda and FITC and PE, and we've also used it with an APC. We get them into the cell, and it works really nicely. So here I look at the number of viable cells, and I only have 2,600,000 and whatever. But my plasma cells, I have a lot of plasma cells. So this is when I take my number of myeloma cells over the number of viable cells, I got 0.663% myeloma MRD. But in this patient, we also always look at peripheral blood in our patients. We do the same gating strategy to look at peripheral blood, where we have our time gate. We get rid of doublets, and we have more doublets in peripheral blood than in bone marrow. And we do our 38 versus 45 and our 38 versus 138. We have to check back and forth between them. And then we have our forward versus side scatter to get rid of debris and granulocytes. And when we do this, we see that we have some CD45 negative, 19 negative, bright CD138, dim CD81, dim 27, and bright CD56. And when we do our intracellular staining, actually we had more cells put into the intracellular tube, and we get a nice kappa monoclonal, and this is 0.006% MRD. So our clinicians consider peripheral blood involvement to be a bad sign. So MRD analysis in peripheral blood can also possibly contribute to management of patients. Now, case 3, we have a 78-year-old male with a history of myeloma post-therapy, and we get bone marrow aspirate. So I'm looking at time versus forward scatter, and we color the events basically because it makes it easier to see the fluidic disturbances, because you see a clearness behind it, so we color them. And you can see we got a good fluidics, no problems apparent. My singlet gate, very few doublets. And I'm going to have to determine my number of cells, and so we look at forward scatter, and I bet that's something of interest. But I have debris. So these are my initial gates. So looking at CD38 versus CD45 and CD138 versus 38. So I've got my this 3845 gate. Those cells are colored pink here, and this 138, they're colored green over here. So I can look at them, and you can see here when I actually open the gate on these cells and look at my CD38, 138 gate, I've got a good inclusion of the plasma cell events. And when I couple all my gates together, I have CD19 negative, 45 negative, dim CD38, but 138 positive, negative for 19, negative for 20, negative for 56, negative for 27, dim CD81. When we do our intracellular light chains, you can see that it's kappa restricted. So we have 429 myeloma cells and a little over 3 million viable cells, and our MRD is 0.014%. Okay, here we have a 79-year-old male with a history of myeloma post-therapy. And here's our time gate. It looks fairly good. And our singlet gate. Sometimes for drawing a singlet gate, we will reduce the number of events shown so it's easier to make a gate. Then I look at CD38 versus CD138, and I look at CD45 versus CD38. And the cells from this gate are colored blue over here. You can see they're extending way into here. And the cells that are in here will be colored black over here. Excuse me. So you can see that I've had to extend this gate over because I have this dim CD38 population, and it overlaps with other populations in here. When I combine all these gates together, you can see I've got debris here. I don't want that. But I've got a nice cluster of plasma cells with variable size. So when I string my plasma cell gates together, I have this 19 negative, 45 negative, 38 dim, 138 positive, negative for 56. Here we have partial CD20. And we have some indication that these patients may have a worse prognosis when they're CD20 positive. That's just in our hands with our treatment protocols. CD27 is dim, and CD81 is dim. So, okay. Now, we're going to look at intracellular, and if we pull up through our plasma cell gate in our intracellular tube, you can see that we have this 19 negative, 45 negative population. We're going to color that, and you can see that these are all kappa positive and lambda negative. And we have an internal control for our intracellular light chain. If you do a good intracellular light chain assay, you should see these normal plasma cells. You can do it with any bone marrow, and if you acquire enough events, you will see plasma cells. And you should see this polyclonal picture for your normal plasma cells. That's an internal control to let you know it's worked well. And in this case, they were 117 positive as well. So those are my cases. And I showed you a number of CD56 negative cases, not because they're the predominant case, but you should realize that 56 can be negative and that you can't rely just on that. And I showed you the normal case, what it looks like with this spectrum of CD19 positivity in normal plasma cells and a little bit of CD56, and how it looks. It looks different than that nice homogeneous pattern. There was a famous flow cytometrist, Carl Stewart, who worked, at Livermore Labs, and he liked to eat, and he described, is it a hamburger? If it's a hamburger, it's homogeneous, you know? And so he had correlations to food for most descriptions of population. So if it looks like a hamburger, or I always say, if you can put your finger on it and cover it with just a little finger, that's homogeneous. So these are the way you look for it. You look for that pattern and that sort of scattered population, like something random, like you threw something out, you know, like you threw beads and they just go shh. That's the kind of thing you see in normal plasma cells with their CD19 or CD56 positivity. So, any questions? Okay.
I'm starting with the time gate. How mandatory is it to remove the events when you have a drop or a drop in the time gate? And does it actually make a difference in the final MRD values?
Okay. In what gate?
The time gate.
Time gate. It makes a difference in how they look. If you have a fluidics problem, it's terrible to go through your whole analysis and you're looking at it and you go, this is crazy. What's happening here? This looks really weird. Well, you know, you check. Somebody did something wrong with the cocktail, or what was wrong with the instrument? You go back and forth, and then you look at the time gate, and you go, oh, there's a partial clog right there. You gate it out, and it looks beautiful. And the thing about having a time gate is, if you don't have that time gate, that is lost. The specimens, the data is compromised. If you have a time gate, you take what's not in that area, you take before it. And then you have good cellular, data, and you use that. So it saves you. And when you have highly cellular specimens that you're running through and acquiring a lot of them within a day, we find that we tend to get, occasionally we'll get potential clogs. We have to do a lot of hot bleach cleaning of our machines because they just accumulate crap in the probe and things like that. It's just a part of running it. And if you do a few cases a week, you're not going to see it. But when you're running cases all day long and a lot of cells, you can get that one specimen a day that might have like a partial clog. It happens towards the end of the day, and it saves you.
Suppose I have a sample with low cellularity, and if I'm removing by the time gate some events, and my count is going to drop further, should I still remove those events, or should I keep it? And
well, the only reason why you would use the time gate is because your data is not good. You have all those events that are crazy because you have fluidic disturbances and it's hard to interpret. And when you move, you can't tell what's normal and abnormal. It's when you have really a very poor result, test result, and then you go back and you gate out using the time gate the bad data, and then it gives you good data. It's a way to save you when you have a problem with your machine. And that's why we do it. And I like to know up front if I've got a problem with my fluidics and how big a problem is it before I go and analyze and pull my hair out trying to figure out what's going on. And it makes the data, when you have a bad fluidics, it makes the data look bad. And you're like, oh, this looks terrible. What happened here? But I look at the time gate right away. So, and if you're doing a lot of specimens, and especially if you have a concentrated specimen, because we concentrate down like 5 million cells that you run in a small volume that you're running through, you're going to occasionally have partial clogs, not a full clog that the person who's acquiring it really recognizes, but like a little partial clog, a disturbance. And then it might actually clear later on because, running enough fluid through it, whatever was clogging, it pops off and goes through. So this happens when you have a high volume, high cellular content specimens. It saves you. It is extra data to save, but if you ever have a fluidic issue, you love going back and just going, cut that out. I'm going to go with this plus this, and I have all good data, and it makes your life easy. Okay, who's next?
Thank you.
Thank you.
I also want to emphasize when you're doing your intracellular controls, intracellular light chain, use your normal plasma cell as control. We always look at them. We don't just gate on the abnormal plasma cells because you'll see a nice polyclonal pattern, and it's great. It's internal control. You've got a process control. You know you had a good staining process, and you had good acquisition, so it's good.
For demonstrating the quantity basis of antibody. And now I would like to call upon stage Dr. Ritu Gupta ma'am for a live case. Already.
But you have HDMI there? लैपटॉप बराबर वीडियो लगाना है लाइव केस नहीं दिखा सकते आपको सॉफ्टवेयर में चलता हमारे पास लैपटॉप बराबर
Next time, you make it.
Six, 8, 7, 4 4 in.
हाँ एक्सेस कर सकते हैं इधर रख के इधर कर सकते हैं आप इधर रखिए आप
Beyond कर
इसको ड्रैग कर दिया
अच्छा इससे भी तो
नहीं
चलेगा।
हाँ नहीं आपको इससे ही करना पड़ेगा ये इसको ड्रैग कर दिया अंदर ये वाला है ये आपको इसी से एक्सेस करना पड़ेगा
You need any chair so that you can sit over there. I can stand.
और यहाँ रखना तो इस पर रख सकते हैं
I think ये इससे भी हो रहा है।
नहीं इससे नहीं वो ये स्क्रीन पे चलेगा वो इस पे आपको शो करेगा
अच्छा ठीक है।
ठीक है इससे भी कर सकते हैं हाँ
हाँ।
वो कर सकते हैं आप इससे भी
तो this is easy ना?
हाँ ठीक है
कर लूँगी मैं। I'll toggle. So you'll have to bear with me as I toggle from the monitor screen to my, as I toggle between the laptop and the monitor screen. So this we are going to do the analysis in the Calusa software. So I've already opened a case. So now if you look at the time and the forward scatter plot, that is the first plot that we use generally. So you see that there is some uneven events over here. So I need to gate this population. So I'm just going to gate this. Yes, let's try from here. All right. So here I'm going to take the BA events. So this is my second gate, which I have put forward scatter height versus area, and this is the difference in the software where the height is being represented by the FS peak and the area by the integral. So now you see that I have removed the doublets here. There are quite a few here in this particular case. Then we go on to our next. I think I'll have to do it from here. I'm going to drag this gate down so that we can see rest of the colors, color precedence down. So now we have removed all the doublets here. Now if you look at this plot here, I have put a 45 versus side scatter plot. And I have just gated a small number of cells arbitrarily, which are bright 45 and very low in side scatter. So when we go to the next plot, you'll see the importance of this plot. If you look at this plot where forward scatter versus side scatter has been gated. So if you look at this plot, I wouldn't have known where shall I cut to remove the debris. But now I know, because 45 bright versus side scatter are my mature lymphocytes, so I do not have any debris in this gate here. So I just move ahead and put a 38 versus 138 plot. Which is here. So after that I use a 38 versus 45 plot to further streamline my population. So this actually was set up on another case. So here you see that there are few events which have been left out. I'm going to just include these events and see what we see. So I'm simply going to include all the events here. This is a slightly broad gate. We can always go back and then manipulate the gate later on. I'm going to remove a few of the gates so that we can. So now I normally do put another gate in kappa versus lambda. I'm seeing this gated population of plasma cells, which are positive for 38, 138 and have variable expression of 45. I normally put one broad gate on kappa versus lambda to remove the unstained events or some debris events from this area. Then if we look at the 1956 plot, I do see a population here. I see the population separating out and merging over here, but I don't see a very clear separation to draw my gates. I look at 1927, I don't get a clear separation, but now when I look at 56 and 27 plot, I see a very clear separation here. So I'm going to gate these cells and see what they are going to tell me. I'm going to include all the 56 negative cells in this gate. I'm going to just highlight these cells using the show rare event feature in this software. So now you see that we have this 56 negative cells which are showing some are 27 bright, some are 27 dim, and they're sitting on top here in 19 versus 27 plot, and they're sitting down here in 1956 plot. Now let's follow these cells further. So if we look at the 19 and 81 plot, so can we differentiate these populations? 19 and 81 plot, I'm going to look at the AZ population. It's already there. I don't see any of my BC cells here. Let me change the resolution. Alright, so we need to change the color precedence. It's already there, it's alright. So anyway, we can't make out much over here. Now let me see the kappa lambda plots over here. So let's look at the kappa lambda and let's look at the BC population here. There are too many cells here. There are some lambda positive cells, but there is a distinct kappa excess. So what are these cells which are coming here? I'm just interested in looking at these cells. Now let me shorten my gate. Let me look at this population, which is 27 bright and 56 negative. So now if I look at this population, I get my kappa positive cells and my lambda positive cells here. And they are showing up here that these cells, the green ones, are essentially my 19 positive cells. So they form the same pattern. That's part and parcel of the same population. as you can see, there are quite a few cells which have not taken up any stain. So there is a problem in this particular experiment. There is incomplete permeabilization. And many of the cells have not taken up the cytoplasmic stain and they're negative. So this is just to show you what problem practically we get in some of our cases. Based on just the aberrancies, we can figure out that these cells express 56, they have dimmer 27, so 2 of the aberrancies are there, but these cells are getting segregated with respect to 19. Some of them are 19 positive and some of them are 19 negative. Or there is a heterogeneous expression of 19. Whereas the normal cells, they are polyclonal, and even in the normal cells you can see that there is a kappa excess. But more important to see is that even in the normal plasma cells, you can see that there is failure of complete permeabilization of the plasma cells, and some of those plasma cells are not showing the expression of any of the light chains. So I'll just show you another case where we see a good permeabilization and a good segregation into the normal and the neoplastic plasma cells. So how many of you have experienced this incomplete permeabilization in your practice?
We get it because rocketing in Japan lambda.
Yeah.
We usually get it, but what we do is we exclude those events
Mm-hmm.
and then calculate the rest of the plasma. So we don't bring them into consideration. After, but what I do is in our gating, after we purify the power scatter, side scatter, and then we put a gate for kappa lambda, and then remove the dual stain cells, and then rest of the cells are analyzed. But anyhow, the kappa lambda dual staining will not be more information also.
So what do you?
It is not persistent. It happens randomly, not for all cases.
Not for all cases, yes. But most often in our
Mostly those cells are not common.
Yeah,
They are including some additional cells.
Yeah, we are not excluding the programs.
So let's look at this case. So we'll start with the time gate. There is actually no need for the time gate. The events are pretty uniform across the entire spectrum. If you look at this doublet gate, I'll just increase the resolution to the maximum, and we can actually reduce the number of events also. So you see that this is the doublet discrimination gate, and now I will also put one small gate for the lymphocyte so that I know that I do not have debris in my forward scatter versus side scatter area plot. And now if I go to my 38-138, this is a relatively neat population. So case to case, you'll have to move your gates a bit in the template. So normally this gate is generally made wider so that we don't lose out on any of the plasma cells, and then we can always refine this gate in the next 45 versus 38 plot. Now you see a tail over here. This is coming from the edges of this population, and they're probably the little bright 45 bright, they're the hematogones, which is slightly less bright for CD38 as compared to the plasma cells. So I'm just trying to get them out. All right, now if I look at these cells, AX and kappa lambda, these are the rockets, some of the cells which probably are coming from the sides, and possibly we normally do get our hematogones lying here showing non-specific staining. But if you look at this pattern, it shows a normal kappa lambda pattern, right? Polyclonal. But now let's look at the other markers in this plot. So now we are looking at 19 versus 56. Can you make a differentiation into different populations? I can't. Now when we look at 19 versus 27, even that is not very helpful. Let us look at the 56 versus 27 plot. Clearly you can see a 56 positive and a 56 negative population. Let's gate them out and see what does it show us. So now, let's look at kappa lambda in this population. So this population is nothing but polyclonal, right? And if I look at the remaining population, which is anyway the major population, that is also polyclonal. So now, it is a 19 positive population, which is some amount of 56. It is segregating with respect to 56, but both the populations are polyclonal. So this is what I was talking about, that you do get 19 positive as well as 56 positive normal plasma cells in your cases. So at this time, although people may argue that 19 plus 56 plus positive cells in a regenerating manner represent the regenerating plasma cells and you should not take them as abnormal plasma cells. But I don't know, I find kappa lambda quite reassuring in these cases. And if you look at 27, even that is not downregulated on these plasma cells. And that is the reason why we take at least 3 immunophenotypic abnormalities, presence of 3 immunophenotypic abnormalities to call them as positive for MRD. I'll just show one more case to drive another point. So it's more or less the same kind of strategy. The only thing is that I need to change my gating strategy a bit. What I'm going to do is I'm just going to put a gate over here in 56 versus 27. So can you appreciate the difference in the expression patterns over the period of months? I'm not refining the gates too much. So now if we look at this, I'll have to reduce the number of events over here. So we had a few events which are 56 negative and 27 positive. And And if you look at these events, they are polyclonal, the orange ones. And they are positive for 19, they are negative for 56. But if you were to look at the bulk of the tumor, in the 1956 plot you cannot differentiate, but in the 27 versus 56 plot you can very nicely differentiate between these two populations. Because this is 27 positive and 56 negative, and this one is 56 positive, 27 negative. You look at the bulk of the tumor, which is kappa restricted, whereas it's orange normal plasma cells. So it's the reverse of the MRD. It is a diagnostic sample where you get the normal plasma cells over here. So why I'm showing you this is just to home the point that 2756 is a better plot than the 1956 to differentiate between the normal and the malignant plasma cells and to put the gates for further analysis. So even if you look at the 19 versus 117 plot, you can see the orange populations are way down here. So what our experience has been that 117 is very dimly expressed on the neoplastic plasma cells. So if you have the normal plasma cells, you can really see the neoplastic cells lying a little above the normal plasma cells. Otherwise, we are always thinking, that they're just below the threshold for the positivity for 117. So in our previous series also, this is what we have observed. Dr. Stevenson may share her experience in 117. We always see a slight gradation from the normal plasma cells in 117. We have never seen a very bright expression of 117 in plasma cells. Only a very rare case do we see that. Then if we look with respect to 81 here, oh, I'm sorry, 81 is not there in this particular tube. But yes, one can see, look further. This is another point that I wanted to make. A very dim expression of 117 on malignant plasma cell is there. And the second is 27 versus 56 plot. So that's all from my side. Shall I stop sharing the screen?
The other one, blue one, this side, blue one.
I think उन्हीं को बुला
Okay, but anyway, you go to team viewer over here.
टीम व्यूअर आपके पे डालना पड़ेगा
हाँ,
ना?
वो ऐसे भी डालेगा।
हाँ, doesn't matter.
Stop it.
हाँ.
You know what I'm going to do? Because the laptop is going to there, I'm going to take a chair.
I want to ask a question because I found the answer when I started working on my
The system on there. Sleep mode होगा.
But what I read was that hematopoiesis have the brightest, so I was looking for phenomenal center cells have the highest CD81 and the hematopoiesis also are the brightest for CD81. So I was trying to
480 3 0 है ना? डबल 0 हाँ बराबर ठीक है पासवर्ड से इसके नीचे पासवर्ड है हाँ J35 हाँ W9Q W9Q
some negative for everyone and something should come positive for everyone. So when I started looking what should be negative for everyone, see 81 is also expressed on all hematopoietic cells. So we have to make it second one it is brightest in the hematopoiesis, then next is the plasma cells, and then it is next is the lymphoid cells, B lymphoid cells.
right
Yeah. That's right.
तुम टाइम पास कर हम सुनना anyway so we have seen a lot of cases. Now what we are going to do, we have to see how this workshop is working. Okay, so I have a case, you will tell me how to do it. Okay, so we'll go through together and I want 100% involvement from the audience, otherwise I'm not going to move. Then your tea will not be there and then Dr. Bani is getting angry because he has session after this. Okay, so we have two plots. The first two plots are common. You can see the doublets and time gate plot. It's pretty clear. Okay, so what next? Sorry, you have to be loud. Yeah? Viability. Okay. If anybody is not agreeing, you have to tell me. Okay. So I put the singlet gate on the viability dot plot, and these templates are pre-made on basis of the normal samples and everything. And I'll put this one. I have done some cleaning here. I'll just show you what type of cleaning I've done. So what you get when you acquire so many cells, you get generally junk. And it is good idea to exclude the junk like this. 81 bright, 56 bright, you will get only mesenchymal stromal cells sometimes. So you exclude that part. And you have some non-specific binding with 130 and 56, which is going quite diagonally. You can remove that part, while confirming that they are not abnormal or anything is there. So which I have done to save the time. And after that, I have put a clean gate so that you will get nice clean population, and you can start. So we can start here with putting the clean gate here. The Boolean gate, which exclude the jump, and this is your clean gate. Yeah.
Regarding the jump, yeah, Prashant is teaching us this way. He is an expert, but we have to remember that these jump gates have a problem. We have had experience of failing in nucleic because somebody didn't remove the jump gate and the population of interest fell there. So before you remove something as jump, be sure that it is
that's what I say. I check it first whether there is any abnormal anything, and to save the time, then we exclude jump. So you have to see the 56 and 81 bright, you will get mesenchymal stromal cell, which you don't want because 81 is too bright and 56 can come into. And when you look at the 130 and it is going diagonally, you first check whether there is a tumor and then you exclude. So excluded that part, and now you have nice scatter of granulocytes, lymphoid cells, and then there is non-viable cells which is smaller than lymphocytes. How do you check? You can check you can put ungated cells in 45 site scatter, gate lymphocyte based on the 45 scatter, and then backgate and see where the lymphocytes are putting, and you can put a cutoff there. Okay. So after that, so this is the way you can see. Then I'm just putting a 45 gate so that you can see this is 45, and you can backgate and look into the original plot whether it is right or not. So what I'm going to do is to make it ungated so that we have 45 positive gated ungated, and then you check here with 45 lymphocyte whether your cutoff is right or not. Is it right?
We go further.
This tell, well, these are degenerating few small lymphocytes because we are acquiring so many cells. There will be like less than 1% cell. So you can exclude that part. But majority of lymphocytes is a counter that should be your cutoff. So let's go again back to your clean gate here, and then we'll start. And as you say, as Merali says, taught everybody, we are going to start with 38, 138 and 45 type of gating, which is recommended by ELN. So we'll start all these viable cells because we have viability gate. So this is our viable cells, and these are your 38, 138 positive gate, right? So you can see the 138, 38, right? Is that right? You want to change this gate? Is the gate okay? Do you think the gate is right? You want to do anything else? Because this is the case you are analyzing, not me. Fine, okay. Let's move there. Then because we have touched little bit cells which are like below the 38 and which might be coming, including some NK cells, or can be even hematogoles which have 38, or at times you can have monocyte because 38 is normally positive in nicely positive in monocyte, and monocyte has tendency to non-specifically bind with 138. So you can have few cells which are like protruding from here. You can see there is a border. It may there. So we can exclude, because NK cell or monocyte will be 45 bright as compared to plasma cell. So you use this gate to put into 38 and 45. So this was 138 versus 38 gate here. And you can see there is a small population which is 45 too bright. This is the resolution. Yeah. You see these cells which you can exclude, because this much 45 expression, bright expression is not expected in plasma cell unless proved otherwise. Right? Can we go ahead? So next is, now we have gated 38, 138, and based on the 45 we gated our plasma cell. Now what we have to do next? Yeah, one at a time, because it is very difficult. Okay, so the degenerating cells, if it's coming in the plasma cells, dying plasma cells or apoptotic cells, you want to remove. So there is already a plot there. So that was 38 versus 45 gate, right? So let's see, let's put, sorry, 38 versus 45 here. Yeah. So you have some cells, we have nice cluster, and there are few cells which are smaller in forward scatter and a little bit higher in side scatter. Possibly they are dying cells. You can include it, you can exclude it, depending on your confidence. So for this analysis, we will exclude them. Okay, right? Now I have one more plot, just as I mentioned earlier also, which is based on 38 and side scatter. Sometimes it helps. Most of the times it's not needed. Sorry. And most of the times it is not needed, but sometimes if granulocytes are coming and non-specific, then they'll like go this way, diagonally down, but the side scatter can be high. You can exclude it. In this case, it is pretty clean population, so it's not needed. And next is also, because I have seen the 20 and 19E, sometimes it give you a small population of junk which is 20 nicely positive and 19 is also positive. Those are actually either those are immature, means plasma blast, which are 20 positive, or the B cell, part of B cells which are coming in your gate, which we can remove. So this was 38 side scatter. This. So you can see there are few cells which are 22 bright and 19 also bright. Possibly those are just B cells which are there in our gate, which we can exclude. So I labeled this gate as exclusion of 19, 20 positive B cells. So you have cells which are like here, and cells sometimes 20 can be non-specific also binding. So even if we do not like consider the non-specific binding, you can see there are cells which are coming 19 and 20 positive, which are maturing. So it's like maturation pattern where from B cells, memory B cells become lymphoblast and losing 20 and gaining and then gaining 38. So there will be few cells which will be there when you acquire 4.3 million cells. So in this we have seen we have acquired, there were almost 4.3 million cells, right? So this is 4.3. And next is, I mentioned to exclude some cells which will lie in between, which is even if a part of junk or some hematogones are there, there will be kappa and lambda negative. So you can exclude kappa lambda negative population, unless you know the case was non-producing myeloma, which is very, very rare. So you can exclude that part like this. So there are few cells, because we have extended gate below, like 38, so you can have some hematogones, so we can exclude that part here. And you have pure plasma cells which are either kappa or lambda positive. So unless it is non-producing myeloma, you will always have either or kappa or lambda, right? And you can exclude that part by using kappa and lambda. And this is the gating strategy, which is even MSKCC use the same type of gating strategy, where based on the kappa and lambda you purify the plasma cell, because you know either your clonal plasma cell will be either kappa or lambda positive and will be sitting there unless proved otherwise. Okay, so that comes to pure plasma cells. Now we gated pure plasma cells. If you see, we have done the sequential gating starting from 38, 138, then 45. then 20, side scatter, forward scatter, and then kappa and lambda, so that we clean the plasma cells, because for a myeloma MRD or any MRD where you're doing sensitive assay, it is very important to have clean analysis. Now we start to look at plasma cells, okay. So I'm going to put now plasma cells, like we know the abnormal markers which like 19, 56. So I have few plots, we can change them as you want. So my first plot, that's why there are 4 plots in the same parameter, but we will change as per your recommendation, okay. So we'll start with 19 and 56, and then later on we'll change. We want to see different combination of markers, whether which marker will be helpful to detect MRD or to say which is MRD negative. So I'm going to start with pure plasma cell here. These are pure plasma cell. What do you see? Yeah, so 2 population of 56 positive, one is 19 positive, 56 positive, other is 19 negative, 56 positive. Here that say 2-3 populations are there. The question is, can we call it MRD? Right? Because if it is nice tight cluster 56 bright, it is easy to call MRD. But this is not like that. Merely say, like if you throw the bins and they scatter, it looks like scatter because 56 is going variable expression. So I'm not confident to call anything abnormal at this point. Right? So what do you want to do? Because see, if you see, there are so many, these are the markers. You want to see the combination. There is 27, 81, 38, 20, kappa lambda, 56, everything is there. 27? 27, 56. 27 it is. Okay. Here 27, and I'm going to put pure plasma cell gate here. Here 27. Now you see the 27 loss is mostly considered as abnormal, but although you can have abnormal plasma cell with normal 27 expression. So if you see the combination of 27 and 56, you can see the nice variable expression starting from bright of 27 expression to negative 27 expression you have. Then a 56 positive population is predominantly present with 27 positive, right? Okay, this is, you want to try another combination? We have
56 positive, 27 negative.
Okay. So let's see. Yeah, we will go like that also. But let's see first how all plasma cells with all markers, so that we know what is the different markers, how they are expressed into the normal plasma cell. Because it is always good to see all plasma cell than just gated population. Because gated population can mislead you. It might be that even the normal plasma cell is not, if the antibodies properly work or not, if there is something wrong with the cocktail, then you will know. Because you are looking at all normal as well as abnormal plasma cell. If you start with small population, then possibly you can, there are chances of making mistakes. You may not make us, but because you are looking at small population, you don't know how the other populations are behaving. So it is good idea to look at all population first, and then you go as per the gating strategy. Then you gate first small population, then subgate it, and then subgate it, and then look at kappa and lambda. We have already seen kappa and lambda. It looks like polyclonal because nice kappa and nice lambda. So 19, somebody said 27 and 81. So let's look at 27. This is 27 was nice, and this is 81. Here. So you have 81 positive population, you have small 81 negative, 27 negative population. There are cells which are going too bright, 81 population also, but majority of plasma cells are nicely 81 positive and 27 positive population. There are some amount of cells, plasma cells are 27 negative but 81 moderate positive, and a very small population which looks like 27 negative and 81 negative. Anything else? We saw all the markers, or we want to see something else? Let's look at 19 and 81. 117 is on the other tube. Let's finish for this tube. Sorry? 38? 28 and 117 is another tube. So we'll start because this is heavy data. The software hangs if you fiddle too much with this. So maybe 45. 1945 useful combination. Many times the abnormal plasma cells are 45 negative. So you can look at 19 and 45 and all plasma cells to look at how they are behaving. So if you look at majority of plasma cells are 45 moderate. There is small population which looks 45 and 19 dim to negative here in this pocket, and there are some plasma cells which are 19 negative but 45 positive, and the very few plasma cells which are 19 positive but 45 negative. So these are the this is how you look at all markers first, how they are behaving. Now you are confident that all markers or antibodies properly working, internal control is properly working, so that you can rely on if there is any abnormality. So generally, what I start, because 56 is a common abnormality, 19 negative 56 is, if you look at the literature also, 70 to 80% population myeloma generally positive for 19 negative and 56 positive. Start with that. So maybe we can start with that. And then we have three populations, right? 19 positive, 56 positive, negative, 56 positive. There is 19 negative, 56 negative, and there is one population which is both 19 negative and 56. Now, just thinking my laptop should not hang. It's the problem of heavy data. So this Kalura software is not that efficient to handle if your laptop is not enough. Okay. Yeah, it's back. So we have three populations. It looks pretty normal, but sometimes you can have myeloma with 19 positive also, which although it is rare, but you can have maybe 1 to 2% of myeloma can be 19 positive. So you want to check. You want to check with this population. You want to check with this population. You want to check with this population, because 56 and 19 negative is considered as normal population. So it is not a tight cluster, but still you want to check whether these are clonal or polyclonal. Yes or no?
Yes.
So let's check with that, and let's see one by one gate. So we'll look at 19 positive, 56 positive, which possibly should be normal only. So 19 positive, 56. Oh, this was the gate. I labeled it wrongly, but this was the blue. So it is nice polyclonal. You can see beautiful polyclonal plasma cells, nice separate from each other. Then there was another population which was 19 negative and 56 negative. It is also polyclonal. Then there was population which is 19 negative but 56 positive. It looks like there is little bit kappa more, but the ratio is okay. It's 75 to 21. Still, it looks like they are polyclonal, isn't it? So although 19 was negative, 56 was positive nicely, they still look polyclonal plasma cell. I'm not sure whether there is any abnormal plasma cell in this. But let's see, we have other markers to evaluate.
Look at cluster that lambda. Look at cluster is there.
Hey?
Lambda that.
Yes, this is because these are because you have selected plasma cells, just selected. So that's why if you look at all plasma cells, there will not be any cluster. Look at there, this is just the part of all plasma cells. So because we have that's the issue. When you are looking at only small cluster population, you have to be careful when you are looking at, because you will have, and that's why whenever you have to look back. So that's why we started with all plasma cells, how the kappa number, how 19, 56, 27, and all markers are there. Okay, then other combination. So 1956 combination did not work. Let's see 19 and 45 combination. Does it give us any answer? So we have seen there is 19 negative, 45 positive, 45 negative population is also there here. which can be also abnormal phenotype because 45 can be deemed to negative, but even normal plasma cells can have similar type of phenotype. So how do you confirm? So you can look at light chain restriction, kappa and lambda. So if you look at 19 negative, 45 negative population there, here, they also looks pretty polyclonal, 70 as to 28 ratio, right? So now it's getting difficult. Most probably it looks like the MRD was negative. But you all know that if I'm showing this case, there should be something.
So there were two populations. One was there was a population which was 20 positive, 19 negative.
Yeah.
And there was one population which was 56 bright and 27 negative.
So let's look at 19. Let's make it instead of 45, we can make it 20. And look at that. Right. So this was this population. Right. So if you
19 negative, 20 positive.
Yeah. So let's look at first this. It looks polygonal. And this one here
2756.
2756, not 1956, 1927. Let's go to 19 and 27 so that we'll see how the 19 and 27. If you look at 19 and 27, there is a nice cluster which is 27 negative and 19 is also negative, right? So which looks suspicious to me because 19 and 27 both are negative and 27 is normal. So we can look into that also. So we can focus into this population, small population, or let's first start with the bigger population because we might have some population here. So we can start there and we can check with our light chain. And it was 19 negative, 27 negative. Where is the gate? Okay, here. And again, here, because we are selecting the gate, again, this is that type of lambda is showing, but otherwise, if you restrict this population, you can see this is more or less chunk only because which is coming in the between. So it is not true because our kappa and lambda, if you look at kappa and lambda should be positive like this. This is more or less junk which is coming in your gate with 38 and 138 and that's why it's 19 and 27 is also positive. So most of the markers are positive. Let's get this population and see how they were in the beginning. See that's falling in the middle. The 45 is pretty bright. You can see the 45 is pretty bright, indicating that possibly they are not be a plasma cells or even B cells. So we have gated something which is not plasma cell or B cells and which are coming in your gate. So see, look at here. See, right, the 38 is also not right. Look at them. So we have not cleaned it properly, and that's why your kappa and lambda gate is so important, not only for diagnosis, but to look at whether you are including something. Now, otherwise, that 19 negative, 27 negative population looks so beautifully abnormal. And this is why it gives me, because kappa and lambda is not coming, it is coming in the middle. So kappa and lambda is coming in the middle. Otherwise, all other plasma cells, all small subsets showing nice polyclonal kappa and lambda, other than this population, because this population is not plasma cell. And we can exclude here. Now again, we can start and go down, and that population is gone from all everywhere. Although there is some population still is there, but you know now that this is why it is important that kappa and lambda is needed. Okay, so next combination is, as Kunal said, 27 and 56. So we have 27 and 56 also. So what or we can do, as somebody suggested, that we can go to sequential gating, or we can look at sequential gating, or first let's look at, as Kunal said, pure plasma cells, and there are some population. Okay, this is 19 and 56, right? So there is some cells which are 56 positive, but 27 negative. So which again looks abnormal because 27 negative and 56 positive. We can look at this was 27 negative and 56 positive, And can we call it abnormal here? No, because there is no tight cluster. There is scattered events, but you can always look at kappa and lambda here because we have kappa and lambda. So 87 negative 56 positive. Now if you look carefully, it looks like again 75 to 25. Right? So
there is a cluster right. Can you tighten?
Okay. So there is a cluster which is 56 right and 27 negative. If you look carefully, there you are. So you have very small population of all kappa positive. It is 27 clearly negative. It is 56 positive. And if you look back, where they lie with 19, 45 and everything, we can start like that. So we can start with first looking at 19 and 45 positive, 19 and 45 negative. So instead of starting a pure gate, if you start with 19 and 45 negative, they are all gone. So let's start with 19 and 19 negative 56 positive. Here, I'm putting wrong gate. Yeah, because I shifted this gate and change this. This was 1945 here, and our gate was here, right? So it should be like this. So if you start with 19 and 45 negative or 19 and 56 positive, let's do the combination. So 19 and 45 negative, we have population here, and again I will extend this part to see how many events are there. See that 19, so 19 negative, 45 negative, we gated that population, and then we gated with 27 and 56. Now we have a population which is clear-cut kappa positive, which is 19 negative, 45 negative, 27 negative, and 56 positive. So 3 abnormalities, actually 4 abnormalities: 19 negative, 27 negative, 45 negative, and 56 positive. And they are on the top of them, all are kappa restricted. And if you look at the number of events, there are 20 events. If you calculate 20 events out of 4.35 million, what is the amount? Can you calculate?
Roughly 0.005.
0.005. So this is just a case I am demonstrating that if your processing and everything is right, you can gain that sensitivity also. And not only the abnormal markers, they all, of course, they help, but at the same time you can see they have so much variation. You can see so many polygonal plasma cells with this marker, and that's how, if you have combination of all markers, like Dr. Mithu said, 3 abnormalities or 4 abnormalities you have, or you have in addition kappa and lambda, you can confirm that there is abnormal population.
Can you see any event 45 side scatter?
Side scatter. So we started with side scatter only. Yeah. So we started with, I said, we started with side scatter only. So they should fall in this because this was our gating strategy, right? That works. And yeah. Where? नहीं वो एक्चुअली अच्छा वो कलर मैंने उसका डी कलराइज किया हुआ है
Upper arm can be discolored, sir. That would not hide.
Please even check the
let me see, please be there now. See, here they are. And here, what is not shown? Yeah, because I had switch off all the colors there. And this is. Showing.
This Korean one.
We have labeled it 27. Yeah, this is. Yeah, so here they are. You can see the cells are here. The cells are here. Some of them are large, some of them are moderate. So they are little bit spreading here, but they are all in our gate. So this was our gate.
events below a negative detection level is there.
So it was still not a tight cluster, no? The 2756 case that we used.
Yeah, it was not tight cluster. So if you are looking at such a low level MRD, you may not get that tight cluster because you are looking at 20 events after 4. So if you acquire few more events, then you get tight cluster. So when you are going to such a low level sensitivity, 20 events may not form that tight cluster. But you can look into the other tube and you can always confirm with the few added by acquiring few more events in such type of case. Yeah, we have LOD of 20 events, but generally this is one tube. We have another tube, so you combine both the tubes. So in other tube also there will be 15-20 events and you confirm the diagnosis. Here it is very difficult to upload two tubes. That's why I'm not uploading. But we should switch off this large event gate, otherwise it will just get a lot of space. Okay, so I think we are already 3:30. We can stop here. 3:30 का यहाँ पे program है. Yes. So shall I stop then? Yeah. Thank you. Yeah, I know you are expecting few more cases, but our time is limited. I have few cases, but I don't think so because you got an idea that how you have to do the analyze, how the gating strategy should be done, and when you look at the different markers, how the different differential expression changes with the mature and normal between normal and abnormal plasma cells, and how you can combine different parameters, different markers with each other, so that you can nicely get abnormal clonal plasma cells, and you can confirm with cytoplasmic kappa and lambda.
We use the ready order 15 to 20 minutes. So either we can have one more case in house or we can have the money stop there and we can continue for the day. That is the last.
No, you tell me. I have one straightforward case which is.
One case.
Now this is another tube from the same case. So we'll go to the other case. But how this 38 and 138 look, you can see how the 38 and 138 you can use for the gating, and then you can go look for the 90 and 45, and then you know that 45 negative, 56 positive population was your population, and there also 27 population. There we had 20 population. So it is more or less same number of population. So if you take this 4 million and that 4 million, that is like 8-9 million, and you are now 40 events, so we can say your limit of detection and limit of quantitation has met. Take some time to load. The earlier case was already loaded, so it was easy to go. Now, if you are using Kaluza or Infinisite, we tried both. And if you have high number of events, you need very good computers also. Computation power, like a gaming laptop. So this is my gaming laptop, so I'm able to open it here. Otherwise, you need a really good, and it is also taking time. So in our lab, I mean, most of you possibly know that we have workstations. We have like 4 or 5 workstations, which cost 8 to 10 lakh rupees, which can handle this type of data. It is like next generation sequencing. If you are looking for next generation sequencing, sensitivity increases. They also need really big workstations. So in the same way, if in a flow you want to do, then otherwise you need high computational data. But like there are some softwares which can handle the data with even the average kind of computers like FCS Express, which can be used, but it charges a lot nowadays. Like per case, it is charging $20 something for analysis part, clinical cases at least. Let's just crash over. Till this case load, if you have any questions, we can discuss. Mary Alice is here, Dr. Ritu is here.
For a beginner like me, we start and market money. Know whether it's the right thing to correlate with the M.
Sorry, what last part I couldn't.
Can you correlate the MRD with the M protein?
See, this discussion even with clinicians, I have seen, like if you look at any IMW or the myeloma meeting, that's always there. If you are M protein positive, do you still want to do MRD or not, right? So when the few meetings which held in India, they are saying if you are M protein, because you know the M protein is secreted by plasma cell, so possibly you don't need MRD unless you are doing some clinical trial or clinical practice, routine clinical, standard clinical practice, you may not. But if M protein is negative and still you want to confirm that if there is residual disease or not, then possibly the MRD will help you. But for clinical trials, if there is any clinical trial, you have to do it. So for clinical trials and for standard practice, that's different. So I think in May at Acta there was a meeting of Indian Myeloma Working Group. All clinicians and the pathologists we were there, and same thing they discussed. Even the people from the Mayo Clinic were there. Everything they discussed, like if in clinical practice it is should be done in the cases where the M protein is negative. If the biology is if by M protein wise it is in CR, then possibly MRD will help in those cases. Because MRD, one time MRD is not enough if it is negative. You have to do sequential MRD to call sustain MRD positivity. I'm not sure other than the post-transplant setting is if anybody wants MRD yet.
Sometimes you get a blanket from post-transplant is very common for post-therapy also. So that SFLC is very big. That correlates much better than the same.
Yes. Because you can have that type of positivity, so you have to.
So that there are a lot of times they have false positive. The second point is because the half-life of the enzyme is longer, and you will see the results much earlier in the bone marrow of the plasma cells than the complete negativity in the so that is a good reason. So we generally rely on more on SFLC rather than MAD of less than MAD is less than 0.5 to 3. And that's the time I think you can go for it. And SFLC is not.
It's very difficult to do. It's a big. I think the file is too big for this.
Also they want to get MRD of PCR.
No, more VGPR only. So that's why they ask in VGPR only. That's the reason why it is not the CR patients, it's VGPR only.
So regarding
It has crashed 3 times, so we will give Dr. Mani the time, I guess, because it is crashing 2-3 times. My computer. I have to do if I want to. I have to actually first do everything and then we can start. It is very difficult to start like this because otherwise that session is more very interesting because what Dr. Mani is discussing a paper by published by AIUOP, how to interpret the antigen expression, especially in PNL, when to call positive, when to not call positive, what percentage and everything. I think that is very interesting article. So we can move to that article because that is taking too long. My laptop.
Last block.
लैपटॉप ठीक है ना सर? Is there any PowerPoint?
सर आपका इसके साथ एक कनेक्ट करना पड़ेगा, नहीं तो मैं पेन ड्राइव में लेकर भी ट्रांसफर कर सकती हूँ।
What I just wanted is, what is it? So it has
ऑफिस है
HDMI or the VGA? It has the VGA on.
एक्चुअली सर इस कंप्यूटर में दिखा रहा है, हम लोग अपलोड उधर से हो रहा है, उससे हो रहा है, तो इफ यू गिव मी पेन ड्राइव आई विल अपलोड इट देयर।
Yeah, इसमें मॉनिटर नहीं होता।
ओके सर ये सेट करते हैं। सर फाइल लगा नहीं।
Should I do the word predict?
एक बार सर ओपन कर देख लीजिए, आ गया मैंने। उसका लैपटॉप में सर एक सॉफ्टवेयर डाला है, तो वहाँ से इधर ट्रांसफर वो हो गया है। मुझे दिखा दीजिए सर कौन सा।
ये लगी मैं यहीं पे यहीं पे
हाँ हाँ इधर से ही हो जाएगा सर। प्रेजेंटेशन की
Okay. So this paper discussion is a little it's connected with what we are discussing in terms of myeloma. But I just thought that one we will be discussing MRD. But on the other hand, this paper has it's not, I won't say new, but it is something which is updating some of our routine reporting issues in this. Though we will not be exactly following this, but I think this paper covers a lot of material in that, for which I'm sure the group will be interested in knowing. So in the sense that this is a AIEOP BFM consensus guideline for flow cytometric immunophenotyping of pediatric acute lymphoblastic leukemia, published in 2018 in Cytometry Part B. So, as per the paper, just to introduce, this is the Italian group with BFM, AEIOP, BFM, ALL 2009. So they have a trial. So for that, as a part of trial requirement, there was a requirement for standardization of both interpretation as well as reporting of leukemia diagnostic samples. So there were 9 national flow cytometry reference labs providing service to an annual recruitment of approximately 1,000 children with ALL. And the guideline was induced by the trial authorities to elaborate a common immunophenotyping standard operating procedure. So generally, standardization has been a lot of attempts. So this is from the AIEOP standardization guideline. This basically what we will be discussing is their SOP for their trial management, which they have defined. Some of it is not a generally regular practice, but some of it is a combination which can be used in our routine practice. So the guidelines had a following aim. One was to define the marker panel requirements for acute leukemia, immunological blast gating, in-sample controls, then a tripartite or 3-part antigen expression rating of negative versus weak or strong positive, with capturing of the blast cell heterogeneities and subclone formation. So the main interest in this paper as compared to a routine reporting was the way we were going to capture blast cell heterogeneities and subclone formation. There are the refined, and to have a refined ALL subclassification comprising of a dominant lineage assignment algorithm to able to distinguish simple from bilineal complex or mixed phenotypic acute leukemia. So though it has, the title is for ALL, but it is going to, some of their methodology is going to address the issues in mixed phenotypic and ambiguous lineage leukemia. So the reason the way in which they had gone in for the guideline was that they wanted their local practices which they were following previously with some adaptations to meet corporate requirements. So there was the requirement of this guideline came due to improved immunological blast cell gating and the ability to explore smaller populations, more heterogeneous populations than previously possible. There was advances in resolution and sensitivity in determining cellular antigen expression and subclassification and outcome prognostication and introduction of detailed semi-quantitative capturing of the expression types. So they only things to little bit, some of them to just give a background to the way to understand their criteria of defining the subtypes and the reporting. I'm just giving you a background because not everybody would be familiar with this kind of a BALL classification, because it's not very widely followed, but it is what the AGIL classification follows. So this is a BALL subtype which is divided into 4 subclassification of B1, which is Pro B, which is CD10 negative is its definition, and it is very commonly associated with MLL. The B2 is the common type. The B3 is pre-B. So intracellular heavy chain IgM positive is defined by them as B3, and a CD10 negative weak positive may occur associated with MLL rearrangements. The B4 type is like a mature B cell ALL, which will have a light chain positivity. So they have excluded those which have classical Burkitt's morphology from the B4. So that is not considered as an ALL for the AIOP trials. So it may, so they are only going to look at L1, L2 morphology and without MYC translocation. So for the TALLs, they are again classifying into stages. Generally, WHO just requires us to define ETP-ALL. Even their ETP-ALL definition is a little more refinement or a practical refinement for trial purposes for ETP-ALL definition. So that also I'll be covering. So the T1 is only cyto-CD3 positive and 7 positive. TALL lineage criteria is fulfilled, and this can be very rare and is generally reported with T2, because in their trial they not only just want it as a TALL, but they want this sub-classification stage-wise, developmental stage-wise classification of T-cell ALL. Then there is a pre-T2, which by definition consists of more than one of the positivity of CD2, CD5 or CD8, with a surface 3 weak positivity being also allowed. The T3 is CD1A positive and surface 3 weakly may occur. In the T4, CD1A is negative and surface 3 is positive. So surface CD3 is strong and surface CD3 weak positive with TCR positivity. The ETP only is additive to T1 or T2. So ETP is not separately defined, but generally they say it will fall between the T1 or T2. So first you define say it as T1 and T2 and add up ETP. Their ETP definition is that it should be CD1A negative, 8 negative, usually 5 negative, and or weak positive, and 1 out of DR 11B, 13, 33, 34, 65 and 117 is positive. And the ETP, if it is CD5 is strong positive, is still for them it goes into their definition of early T cell precursor if 2 of the markers of HLA-DR 11B, 13, 33, 34, 65 and 117 are positive. Surface CD3 weak positivity is also justified in their ETP definition. So this is again summarized here. So either negative for 1A and 8 and usually CD5 negative or weak positive. This is our standard definition with a strong positive for at least one of our. But in addition to that, a strong positive of CD5 with at least 2 of the above markers in this list is positive. There is also an indication, though it is not a peer-reviewed publication, but it is, they have said that this 371 marker or CLL1 marker is coming, is in publication, is what this has said, as it may be a marker which may be positive in ETP. So the 371 will come to later when they are looking at the panel definitions. So BCP-ALL is, this is not E epsilon, it is greater than or equal to 2 of the positive from CD 1910 intracellular or surface CD22, intracellular 79 alpha, which is a standard definition. TALL, all 3 of. So they have said that you have to have intracellular CD3 positivity, 7 positivity. Intracellular MPO should be negative or weak. AML is greater than 2 markers positive intracellular MPO, 13, 33, 64, 65, 117. And not meeting B cell or a T cell criteria. So first it should not B cell or a T cell criteria followed by 2 out of the positive. So this is what was their definition for treating based on their BFM protocols. So to give a comparison between the WHO and AGIL criteria for mixed phenotype. So the upward table is the WHO criteria which is generally used. And in AGIL, they have given point based on these antigens. So it will require that we do all these antigens for typing. So lineage assignments, there is something called as a dominant lineage assignment where they want to know what is the predominant population in a mixed phenotype being positive. The BCPLL needs a strong positivity for two of the four antigens, and in rare cases CD19 negativity, specifically CD10, must be strongly positive. So in these cases, this is the way they have defined it as a B cell lineage. A rare case of MLL may drop out of the scheme due to biology inherent to lack of CD10. So in this, as well as weak CD22 and 79 alpha. So, but CD19 they are saying in MLL will be usually positive, so that alone may be a marker, and that's the only exception not to follow the 2 out of 4 antigen criteria.
This is particularly important because nowadays we see the cases where you have one population, there is another population. And now myeloma is just, shall we call it mixed phenotypic, or we just mention it another population, or to do it because we see now when we acquire 2 to 3 million lakh cells in each two for acute leukemia, you start seeing this type of population, right? And because this is the only article which touch this topic where what will go down. They specifically mention dominant population. Because otherwise you know all that either they should be positive or negative. If you look at WHO, there is no criteria for what percentage should be there to call mixed phenotypic, to call the dominant population, but this article at least mentions the dominant population and small population, something which we have to think, because we see such cases. We cannot call them mixed phenotypic because they behave nicely. We have seen cases which were in AML, the small population, which later on was okay because they did not change the treatment and they behaved properly because it did not relapse. Or in ALL case, it is a small population of myeloid blast. Well, they get treatment of ALL, which is the same. The treatment is same for mixed phenotypic also. It doesn't matter what we call mixed phenotypic or it is a predominant population. And that is the importance of this point, I think, the lineage assignment, because this is practical concern we see in many cases. Yeah, AML is compulsory venture, but what about monocytic leukemia? In monocytic leukemia, you don't have anything.
And zero,
you cannot have.
More than 2 markers they have mentioned. In that LP1, the rest of the markers.
Absence of DNC also.
Okay.
In absence of DNC.
I would just.
Yeah.
So I think I would just like to continue. I will give a break at the time when we will come back to this point, so that I think a lot of discussion points will be answered subsequently in this, in the sense that the intracellular CD3 positivity must be either strong or if rated weak. This is one of the things, because sometimes you do get small subclones which are CD3 positive in a otherwise myeloid leukemia. So they said it must be strong, and if it is rated weak, there should be CD2 and or CD5 should any of them should be positive in addition to 7 and 3. So 7 cyto3 if cyto-CD3 is weak, because this is especially important in certain, mainly in ETP-ALL cases where cyto-CD3 can be pretty weak in some of the cases, and it will be very difficult to diagnose them as one way or the other. So it's very liable that they will maybe said as myeloid leukemia. So surface CD3 expression needs to be tested in addition, which most places do as a routine. So sample acquisition, this is just basically for the trial purpose. So it is bone marrow. They are using a stained lyse procedure. Additional staining of live cell permeant dye was something which was interesting, but they have said this should be done mainly when there is a transported sample, as well as all cases where very low CD45 expression in the blast is noted, low to negative CD45. Cell permeabilization and intracellular staining using commercial reagents as per manufacturer instruction. Sample acquisition, they have said a minimum of 30,000 nucleated cell per tube has to be there, so that you are able to at least pick up to the sensitivity of 1% blast when you are doing a leukemia. So unstained controlled tubes have to be run. So as per their SOP, they are running both a fully unstained as well as CD45 alone unstained control. So the purpose of a fully unstained is to get the background of entire cell population, whereas CD45 unstained, you will be able to know the individual autofluorescence of subpopulations based on CD45 gating in cell. So analysis and gating strategy, CD45 is used as a backbone as usual. Doublet exclusion of events and increased FSC width is mandatory. Assessment of individual antigen expression is done preferably using histograms, contour plots or pseudo color density plots instead of the standard dot plot. So most of the labs in India are doing the standard dot plot. So why do we have to use a contour or a density plot? So the usage of plots with bi-exponential logical display is specifically advantageous, which most of the centers are doing. So the reason why a contour plot is preferred over a standard dot plot is the contour plot allows for subpopulation definition, which is important for many of their subsequent lineage assignments. And so this is just to tell you that if you don't go based on your background, this doublet exclusion, you might have, say, otherwise a BALL having some MPO expression. So this will give problems. So for these expressions, the doublet discrimination is used. This is mainly for people who are very new into flow here. The antibody panel, so they have said that their recommendation is to have at least more than 4 colors. 6 colors is what they recommend as a minimum. Staining approach is compulsory. Should be based on CD45 backbone, against both lymphoid lineages in each tube to pull out leukemic and potential control cells. Choice of fluorochrome conjugated antibody and vendors tube is largely left to the individual lab's expertise except as indicated. Because for me personally, this has been a problem because in India also government has been pressurizing for a standardized guideline for, especially for patients who are getting government funding for therapy. So these guidelines on the one way, there are 2 methodological approaches where you say that everybody uses the same panel versus you leave some amount of flexibility to the panels for individual labs. So this approach looked very practical for as per this group. So screening tube markers, they must include CD45, CD19, 10, intracellular 79 alpha, CD22. So this is only for the laboratories where they first do a screening tube before they put a full panel. So otherwise, if you are putting a full panel, then the screening tube requirements are not essential. But if you are running a screening tube, these markers have to be there. That is the CD45, CD19, CD10, intracellular 79 alpha, intracellular cyto CD22, intracellular and surface CD3, 7, intracellular MPO.
Because we have seen that I have seen in NIH also with medialis, we used to do surface 22 medialis, right? It gives better result than cytoplasmic. Now, after insisting in some cases, you have insisted, why don't you do, the cases where 24 degree. We have done almost 10 to 20 cases.
I think in this paper they have expected it. There is a subsequent explanation coming in why they are insisting on it.
Because it is also the question because we are discussing this paper. So I think
Prashant, let me just complete the panel. Then I'll give the 5 minutes at that time. Otherwise, we will be, discussing something which is anyhow coming in the next slide. So in each has to be combined with CD45. So surface markers, they are insisting on PE conjugation for CD2. So they have said they have left the flexibility in certain antigens, which I have given in brackets. They have said this is compulsory. So they have asked for a PE conjugation in CD2 with CD3, 5, 7. Surface markers CD19, 10 and 20 for B cells. For myeloid, they are asking for a 11C, 11B, 13, 14, 15, 33, 64, 65. So 65 is only available in FITC, so that is why 65 has to be definitely in FITC. CD117, then of course CD34, 56 and DR. And if there is a TALL, then they want the following antigens to be tested. That is 1A, 4, 8, alpha, beta and gamma delta. Generally there is significant reason for testing CD1A, 4, 8 and gamma delta. TCR alpha beta, I think they are testing because they have their T subsetting based on TCR expression. So they will want to look at TCR expression is there in these subtype of TALL or not. So that's what I think it is. The B4 or the mature B suspected, they are asking for a light chain expression, kappa and lambda light chains, both surface as well as intracellular. So the intracellular is mandatory, that is CD3. So they have insisted that it has to be one of these two clones, either a UCST1 or an SK7. For CD22, which Prashant was discussing, they have said only one clone, which that's why they are asking for a cytoplasmic. They said only this clone works very well, which is RFB4.
So the other clones which we use so many years, the surface 22 works very well. So they are not saying like surface 22.
But WHO, as per the criteria, was under cytoplasmic.
So that's what I'm saying. So cytoplasmic, if you look at surface, works better than cytoplasmic.
Surface is negative in so many cases.
No, that's what I'm saying. So we have tried all cases now. We get so many cases of ALL, and we are saying in a surface 22 negative, we tried cytoplasmic. Cytoplasmic was negative. We tried with alternative antibody in clone, it was also negative. So, but most of the cases, means 22 surface and cytoplasmic is not too much different. In fact, the sensitivity and the expression of surface is better if it is positive.
So do you have any cases where surface is negative and cytoplasmic?
No, that's what I'm saying. So we have tried, because Manisha there insists that only. So we have tried in all those cases, we never found like if the surface was positive and cytoplasmic, the surface was negative and cytoplasmic was positive.
So for NP also they are insisting on a specific clone of 86. The reason I am projecting it is most of India, the pediatric ALLs are treated as per BFM protocol. So in all cases, they are saying the following additional optional or recommended markers. These are not essential, but these are optional markers like NG2, 371, which is CLL1. In CLL1, they have specifically asked for it should be PE based and the clone should be 550C1. And if BCP ALL, then there are certain markers for MRD like 11A, 22, 24, 38, 44, 58, 66C, 123 CRLF2 for subtyping, in which the 1D3 clone is specified. And if TALL, CD99 TDT, and if it is biphenotypic acute leukemia, according to the general panel, the CD24 and intracytoplasmic TDT. So the optional markers, the rationale is minimal residual disease markers are these 11A, 38, 58, 99, 123. Then genotype associated markers like 123, 66C, NG2, CRLF2, lack of CD44. These are used to identify underlying molecular lesions. And so the other point which has come out in this paper, but they are saying that it is 371 is useful to pick up BALLs which have a very early switch to monocytic type, rather than the CD2 as has been previously published, because most of the switch work has come from this group. So the next, coming to what really gives us a lot of interperson interpretative variability, is definition of antigen expression. So they are using a combination. So they have said that no reporting by percentages. Antigen expression is determined by assessing fluorescence shift and distribution pattern of the leukemic cell population against appropriate control. So and in appropriate control, first is control for background. So no isotype controls. Then use, if there is a doubt and there are non-availability of internal controls, then you do an FMO. Unstained control tubes, and in unstained there has to be two unstained, one for surface and one for permeabilized or intracellular staining. Different cell types in the sample may have different autofluorescence. So for understanding what is the autofluorescence background of cell of interest in leukemias? They are advising a CD45 alone tube to use CD45 as a gating to know the autofluorescence, and to discriminate blasts from other cell populations according to differential CD45 expression and then estimate the potential autofluorescence. The higher level of the two, the backgrounds from all samples, since they are asking for two control samples of one plain unstained and a CD45 unstained, the higher background of both should be used as your cutoff for negative. So this is just plot from the same paper illustrating the variation in background in various subsets. So if you use the lymphocyte blue background, your background ends here, whereas in a control, actually your blast cells have a higher background than the lymphocyte background. Similarly, so when you're looking at, say, something like lysozyme, it's a myeloid marker, if you use a cutoff here, then your blast population is likely to be positive for lysozyme. Whereas if you use the internal control for the specific population, then it is negative for the lysozyme. So cross-lineage lymphocytes are used. So if you're looking for B markers, T cells are used. If you're using T markers, B cells are used, with the exception of few broad expressed antigens like CD45. So certain antigens don't fall into this lymphocyte as a control. So for CD45 assessment, expression of blast subset versus residual granulocytes and mature lymphocytes, a negative region is defined for each antigen in a sample cell with controls in plots with CD45 or cross-lineage markers which do not express the antigen. So then comes the main issue of antigen intensity grading for the sake of reporting. So the amount of deviation from negative is further used to differentiate positivity into two major categories, weak and strong. A threshold marker is used in case to delimitate negative population and to assess proportion of blasts outside this region. And a threshold of 10% of gated blast is used for all antigens independently from surface or intracellular to be considered an antigen as positive. Threshold markers are not used for partitioning of otherwise single blast populations for reporting of proportions of cells aside from the marker. And in borderline situation,
highlight another. We look at this is the reference for 10% because we traditionally believe 20% cutoff for antigen expression, but this is a good reference because there is no other reference. Because this reference says it is a 10% you can take as call something as positive. Somebody asks you how did you call positive, you say 10%.
In borderline situations, the prevalence of non-overlap of blasts with negative control is quantitated. So in borderline where you are having percentage population, and positivity is only accepted once fluorescence shift is large enough to exceed the potential background variability. So just to put this in figure, so this is their negative, so this is your blue is your based on your autofluorescence cutoff. And it is still considered negative if you have a small population which is less than 10% going into positive. Then comes the strong positive. Strong positive can be varying types. So this is also considered strong positive where majority, more than 50% is shifted away from the negative. Sometimes you can have where there is a good separation between your positive population and the negative, and where your partial positive is where you are having populations in which there is both overlap with the negative. And heterogeneous for the term, they have recommended a definition of 1.5 log variability. So the 1.5 log variability is what they are using as a heterogeneous for visual interpretation for writing reports. So the problem comes in weak positivity very regularly. So dim is a shift to the right of blast versus the control, but with overlap in a majority of peak of blasts. Then in a dim positivity is where there is more than 10% positivity. Partial positivity again is similar where a subpopulation is only positive, a subpopulation is negative where you are having two peaks. minority of the blast but less than 50% of the blast for partial positivity, partially dim. So exceptions to this kind of usage of the lymphocyte as a background for normalization is there that are in CD45, 11A, 38, 58 and 99. So in case of CD45 and 11A, the expression of blast is compared to unstained channel control, negative, as well as to the residual mature neutrophils in the sample which are positive. So this is just explained. So you have your red is your where your blast population lies. So if it is nicely very close to the negative population, you call it as negative. When it is extending to the level of your neutrophil population, that is considered as dim. If it is in the neutrophil population, considered as medium, and above neutrophil population is considered as bright. So in case of CD38, CD58 and 99, blast should be compared with the residual low lymphocyte subset with a higher expression of the marker. So for 38, what do you use as a control? So it has to be a lymphocyte which is expressing 38. So lymphocytes generally have a heterogeneous 38. So you have to take the brightest of the lymphocyte 38 and use it as a level for the control interpretation. So dim positive if lower than that, but not negative. Medium is if similar to the high expressing CD38 expressing lymphocytes. Bright if stronger than the high expressing lymphocytes, which is like in plasma cells. Heterogeneous if it is broadly. So this heterogeneous is different from the 1.5 log variability heterogeneous. So there is a little bit of confusion in the terminology used here. But it is emphasized that this is different from that heterogeneous. The blast percentage has to be recorded. What is the percentage of blast? So what happens when your flow cytometry blast percentage doesn't meet your 20% criteria? So in that case, they have said to report as malignant lymphoblast, suggest your ALL if it is lymphoblast with a low blast percentage is the way the recording has been suggested. So reporting of blast immunophenotype in blast population heterogeneity. So the other thing they want the report to capture is the heterogeneity of the blasts themselves. So they want us to avoid where you're having blasts with varying expression to put it as a variable expression of a single marker. So they want that subsets be characterized. So the lumps together features of immature blast and maturing cells as well, but this is generally a problem in AML, as well as heterogeneous blast population by reporting many antigens as partially positive. Samples must be vigilantly assessed for signs of more than one immunophenotypic blast clone. Such cases should be classified as an extra label of heterogeneous blast population. So the blast population heterogeneity, leukemia with separate immunophenotypically large non-interconnected blast clones typically occurring is bilinear. So heterogeneity, one of the forms is bilinear, where you have two separate blasts which can be defined as two different clones, and a detailed phenotype should be reported for each of the blast clones separately, including percentage among the nucleated cells, lineage and subtype assignment. Then leukemia where there is a branch. So there is a leukemia in which all are connected populations, but they are branching in various directions. So it is reported by reporting antigens as partially positive. So the bilinear cases with complex immunophenotype where you are having two separate clones, but each clone has its own branches, will be clearly separate of different lineages, and further subsets interconnecting the former can occur, which can be best summarized as heterogeneous blast population. Such cases must fulfill the criteria for a mixed phenotype or an ETP, as has been said, and exhibit intra-lineage clonal heterogeneity that would lead to different ALL subtype classifications. So the following antigens are of interest in ALL were only partially positive. So this list indicates to a certain extent the antigens which you have to carefully look whose partial positivity might indicate subclones. They are CD10, intracellular, IgM, the light chains, CD1A, CD3, CD5, TCR, alpha, beta, and gamma delta. So this is just some of the cases in the same case report describing the heterogeneity. So here so this is just to bring, this is CD3, so you are having CD3 variable population which is defining of a TALL with variable CD7, CD2, CD5 is negative, but you do have a population which is showing anti-MPO. So, and all the population is positive for 34, 13, CLL1. So this is showing you the heterogeneity which is there, in which it's otherwise if this anti-MPO is not put in, this should go in as a biphenotypic population, and this contours actually tell you that there are two different populations. So that is where the importance of these contour plots come in, or density plots come in. The IgM, the next is here where there is an IgM positive population and an IgM negative population. So though this would be, and there is a CD3 positive subpopulation in it. So when you look at it, this shows a very complex leukemia in which you are having subpopulations which are not interconnected, as well as they are having branching. So this kind of heterogeneous population is what they are calling, has to be mentioned in the report as a blast population heterogeneity. So in this, they have said this is a case in which was reported as a BALL, but relapsed, and at that time when they looked at the original report, so this was the blast population, which actually is showing a B as well as myeloid. And in addition, in morphology, the monocytic precursors were missed and looked at as a BALL. So the intracellular MPO is positive in a subset, and the 19 is variable. So 34 is there, and you have 64 being positive in a subpopulation. If you see, there are two interconnected populations which are there, and the 64 11B. So this indicates this should have gone initially itself as a biphenotypic instead of having gone as a B. So in terms of, so this is again, blast heterogeneity is for something like CRLF2. Very commonly you will have just a small subset which is coming as CRLF2 positive. So this is a small subset, we cannot call it, it might be less than 10%, but they are saying in such situations this has to be specially mentioned that there is a small population which is CRLF2 positive as the prognostic implications change. Similarly, in these where you are having, this is like a classical bilineal where you are having two separate. One is a purely B, the other is a purely myeloid with separate population. So this should go in as a bilineal. So the reports should have the identification, information of the patient, then samples, the standard requirements, and antigen expression, dominant lineage, which is the major lineage of the multilineage if in case it is there, and even they want a dominant lineage when in their B subtypes and T subtypes. So then they want individual subtypes B1 to B4, T1 to T4, heterogeneities to be put in the report, quantities of individual blast population, and conclusions, that is a total final diagnostic information relevant for treatment choice, and additional information of clinical interest. So this is their full workflow which they have suggested here: sample acquisition, gating on blast, identify blast population, get the blast percentage, complete antigen assessment, antigen expression, distribution intensity with interlineage blast clone heterogeneity, dominant lineage assessment according to the criteria based on the intracellular marker ALL or not, further ALL blast characterization, intralineage blast clone heterogeneity, immunological subtype, mixed phenotypic status as per WHO as well as AGIL, and immunophenotyping report. So this was the first paper which actually has tried to standardize the way we look at, or at least disseminate what we are looking at in terms of reporting in terms of clones. So in India we have a very wide range, starting from percentage based reporting to just final interpretation based reporting. So we are fine tuning reporting as time goes. Thank you.
One thing new was, in the ATPA, there was a remark that 5 prior positive cases, more than 2. How acceptable is this?
This is what BFM follows for trial. So that even I was surprised by that, and I don't think many of us are aware of this kind of a classification.
Right, it's strong because their right definition will be like normal state.
First, what we are used is that if any antigen is reaching the level of the normal control, like CD19, if it is in the normal control of failing positive, we report as moderate positive. So when we report that, but in case of MPAL, the clinicians come back to us. So as per criteria, it should be 19 prior positive, reported only moderate. So how you qualify for MPAL? So then what I difference I give is that there are two, one is Bethesda and another is AAFP. So both the languages which they use is different. I think that is a good difference, I think. Or is there any other difference?
No, in this AIOP, in this case, they have said they are using for their description 2 criteria. One is the Bethesda, where you write moderate, heterogeneous, partial. No, both. One is what they have written as WHO style in inverted commas, which includes negative, dim, strong. That is one. The other is the variability in the expression of individual blasts, like partial, homogeneous, then heterogeneous. So these terms they are put into that.
In your lab, what is the cutoff used to define positivity for intercytospecific antigens? For MPO, because we have cases where MPO will be positive 5%. So, will you, and all viral markers of B markers are positive?
If you ask like that, it is a very difficult question. So when we have 5%, we try to look at the other markers to see whether there is a separate small population which is fully myeloid. So if it is not there and I'm only getting a very borderline MPO positivity, we ignore.
So actually we had some case like that. We had an ATPA where at baseline we had around 2.3% cells which are MPO positive. And not only the MPO was negative, IS was also negative. But same case we reported CTPA with the writer that 2.3% cells have MPO positive. The same patient relapsed at the time of relapse.
So that is what this paper is saying, that don't write it as a single antigen positivity. Say whether there is a separate cell population in that 2.5% which is in addition to MPO having myeloid markers. Are you getting that kind of a pattern? And that is where the major difference of advocating a contour density plot here comes as compared to using a dot plot.
Dr. Ryan, your experience on giving the percentages, if 5% for an MPAR in the intercytospecific antigens, if it is 5% cells positive, you consider it as positive or you just give an error or you don't count?
So 5% is positive for.
And do you, for example, in here,
So it means like when there's variable expression.
yeah, actually it is a VA. Something is right 90 positive.
Right. And so the variable expression of something within that is if we can report the percent of ALL, and we see that there's differential expression for percent of the ALL cells that have some.
You don't quantify that.
What?
You don't, like, if you now it's a debate between a BA represent MR. Debate, like a.
So my second question to you is, would you give a the more simpler way to ask is, if only isolated MPO positivity is there, would you give it as a mixed phenotype?
That is the correct.
If only isolated MPO.
There are articles for WHO.
When WHO mentioned if you are only seeing individual cytoplasmic MPO, you have to be careful before promulgating.
So without a 1333 117, any of the antigens being there, if you have an isolated MPO positivity.
If it is subset and deep positivity, WHO mentioned warns us to follow that. They have warning means you should not. And there is an article from the agency.
There is an article that is stating that what is the role of MPO positivity in B acute leukemia. It is, they are excluding the cases of MLL rearrangement and 922 translocation, and even they stating there's more than 10% they are taking positive and less than 10% they are negative, and they are stating the prognosis based on the MPO positivity in BS.
So that is I think that is what, if we get such a abnormality, we see whether there is pH or not.
So MLL or pH positive they excluded.
In fact, MPO cytochemistry is even more cognizant than the MPO positivity before cytometry or basic mediated damage leukemia. So it is the only entity which is really dependent on the cytochemistry. If you see cytochemistry positivity and MPO is on for cytometry low or dim, you still have the result.
No, if cytochemical positivity is there, there is no doubt.
Yeah. So the reason is when you get cytochemical positivity, possibly it is a different clone which we may make, because although we are using monoclonal antibodies, not all cases will have same epitope, so you may need additional. It's a different clone you may try and put the clone that make positive the other clone. So that is a possible explanation.
This was a very important lecture, and I'm sure quite a few of must have felt that it should have, at least I felt that it should have been in the initial sessions, and must have been of more benefit to quite a few participants. So with that, we end the session for today. Again, tomorrow we'll meet at 9, but we have tea for you ready outside. And I hope that now tomorrow you will not have a trouble locating the telemedicine auditorium, and we can start at 9 sharp again. It's on the same pattern, and tomorrow we'll be starting first with AML, MRD, and then live analysis of AML, MRDs, and how to prepare template for them. Thank you so much, and you can get up for tea. And biscuits.
ये जिसको मन करे इसको आप उसी में ओवर होगा हाँ माउस खास कंट्रोल भैया वहां लगे हुए